begin, Aditi ma'am? We have time.
Yeah, start.
And at the end of it, if you have some questions or no, anything like general things we can discuss, Aditi ma'am, like no general observations and no anything if you want to ask, we can work out. Okay. So who is presenting first today? Sunisha?
Okay, sir. I don't mind.
Okay. Because yeah, Sunisha, you can begin today.
We just.
Reverend Jetta is also not there today.
Is my screen visible to everybody? Yeah.
Yeah, we can see. And your time begins now, Sunisha.
Yes.
All the best.
Yeah. Thank you so much, sir. So the topic that has been allotted to me is treatment settings. So before we go forward with our presentation, I'd like to start off with a small activity called emoji of the day. Okay. So describe your day so far with a string of emojis, people. So how has your day been so far? So can I have a couple of reacts in our meeting today? Oh, I see a couple of smileys. That is nice. Can we flood our meeting with reacts? Oh, great. Celebrations. Smiles. Okay, lovely. So before, oh, I see some sad reacts as well. Okay, we'll talk about that at the end of the meeting. Okay. Before we move on to the next slide, I want to ask a question to all of you. When I say the word treatment settings, what comes to mind?
The facilities or the place where treatment takes place, like a treatment center or a clinic or a hospital, for example.
Sorry, sir, you were cut off. I couldn't understand what you were saying.
The setting is the place where treatment is provided, a treatment center, a rehab, a clinic, a hospital for that matter.
Yes, you're absolutely right. Anybody else would like to share?
Yes, when you say treatment setting, I think treatment setting refers to the place where people receive services, which can be in any form of services, but in this place, we are referring to a treatment for an illness. And so that setting where they can get, it can be a formal or an informal setting. Yes.
Absolutely right, sir. Thank you for sharing. Anybody else?
The client receives the treatment at particular environment and kind of institute. So that defines what is the setup made for them in order to receive it.
Yes, you're right. Anybody else?
Basically, a clinical setup to give service to the clients.
Yes, you're all absolutely right. So a treatment setting is my slide going? 1 second. Yeah. So a treatment setting, you're all absolutely right. A treatment setting is nothing but it refers to the place where we offer our services. Okay. So according to the UNODC, there are 5 different kind of treatment settings that has been delineated. So they are community-based outreach, non-specialized settings, specialized outreach treatment, short-term specialized inpatient treatment, and long-term specialized residential treatment. In this session, I will be talking in detail about each of these settings that I've just named. Okay. So the first setting that we are going to talk about is community-based outreach. So as you can see in the picture, there's a lady there that is talking about something, right? So she's talking to a group of people in a setting that is outside of a treatment center, right? She's interacting with a community. So that is the whole premise of a community-based outreach. It is designed to improve access by bringing the services to hard-to-reach communities. So the main aim of a community-based outreach is to actively seek to engage with the people in the community and encourage people who are using drugs to access treatment. 1 second. Yeah. So before the individual accesses treatment, there is a time between the onset of the disorder and the start of treatment. So the main aim of the community-based treatment is to reduce this time and to reduce the negative impacts of substance use, and to build a positive relationship between the community, between the service provider and the person who is giving the outreach treatment. So it provides an easy access to basic social and health services, and also as well as to avail specialized treatment services for SUDs. So the next setting that we would be talking about is non-specialized setting for treatment with SUD. So these settings have not been designed to deliver specialized treatment. So can we all agree that screening and assessment is a very important part of treatment of SUD? Right?
Yes, definitely.
Yes.
Yeah. So this setting plays a very important and a very brilliant role in being able to provide screening and assessment to the people who are implicated with SUD. So they play a very important role to identify, prevent, treat SUDs, and also deliver brief intervention wherever necessary, and also referral to treatment. So how do we say what kind of settings are non-specialized settings for treatment for SUD? Settings such as primary healthcare settings, emergency cares, general hospitals, smaller setups that give prenatal care, welfare services, schools, smaller prison health services, all qualify for non-specialized settings for SUD. So the next setting that we will be talking about is a specialized outpatient treatment. As the name suggests, this is a specialized treatment setting. So in this, it is also community-based, and they are offered in a wide variety of locations. Like they are offered in community mental health clinics, or community-based hospitals, clinics, public health centers, etc. So these one of the most special feature of this treatment setting is that they provide treatment in accordance to the schedule of the individual. So they do not interfere with the schedule of the individual. For example, the individual is working, or he is going to school, or he is in the process of. Sorry, somebody was saying something. Yeah. So they do not interfere with their everyday activities or their work activities or their schools. So they provide treatment in such a way that they can also avail treatment while their everyday life is not being disrupted. So they vary considerably in terms of components and intensity. As in, they also provide high range intensity program, which is very intensive and also care to the substance use disorder, or they also offer mid-range to low intensity programs as well. So they are carried out, all of these specialized outreach treatment programs are carried out by professionals who are well versed with the SUD treatment and other co-occurring disorders. So the next setting we will be talking about is the short-term specialized inpatient treatment. So in this setting, it provides 24-hour care and also has the capacity to manage SUD acute manifestations and the other acute serious symptoms that manifest with an SUD disorder. So it can be administered in a hospital setting with which specialized in mental health care and SUD treatment, or specialized units, specialized general hospitals, and also programs that have trained staff and appropriate clinical equipment to be able to handle an acute SUD individual. It also brings the opportunity. This sort of setting brings an opportunity to have an intervention where the individual can discontinue the substance with minimal distress and minimal health risk. So the length of the stay also can be controlled here, can be monitored here. It usually varies from 1 to 4 weeks, or depending on the intensity of the SUD, it can be prolonged. So the last treatment setting that we are going to talk about is a long-term specialized residential treatment. So as the name suggests, it is long-term and it is specialized residential treatment. What this means is this setting is a substance-free therapeutic setting that is designed specifically to provide a protected substance-free environment to the individual who is deeply impacted with SUD, and the individual is separated from the chaotic and stressful environments that have contributed to SUD. So if an individual wants a long-term treatment, the individual has to adhere to the norms and rules that are to be followed for the admission into the program for long-term SUD treatment. So usually traditional models include only psychosocial treatment, and at present there are many modern approaches that have come about and that has been incorporated into a long-term treatment. So I think that brings about to almost to the end of our presentation. But I would like to conclude with a small activity. So can we have a small breakout rooms? Can that happen?
Yeah, we can do that. How many groups?
We can have two groups. Yeah.
2 groups. Okay.
And at the end, we can have a sharing of what I'm about to talk about.
Okay, sure. Done.
Yeah. So this is the activity. So I hope all of you have understood the different kind of treatment settings that we have talked about. So based on that, I would like you all to discuss among yourselves, what are the treatment settings that are provided in your country or your region? What are their features? How do they work? And if you identify that there is some need of improvement or you need to strengthen these type of settings, please talk about it, and we can come back after our breakout rooms and discuss in our main group.
Okay, shall we open?
Yes, sir, we can.
Yeah. You have only 3 minutes more, accordingly, no? 3.5.
Yes, sir.
Just go ahead, no problem. It's done. Some are not joined, but you can start the discussions. No? Okay, happening. No? Yeah, you represented. Indian opportunity. I mean, now Nisha's come back. Nisha, you tell us when we should close the rooms.
Yes, sir. I think they only have 1 minute in my time.
1 minute, no worry, no.
Yeah.
We'll close it now. Then I now close it. It take 1 hour to come back, 1 minute to come back. Yeah, close. We'll close it now. Actually, it is like they must be following all the models. No, it is not one single model, OPD and residential and all. So you accordingly close
Yes,
to
sir.
conclude it. Okay.
Yes.
Yeah. Close it. No. After closing, it takes another 1 minute to come back. That's why. Ah. See.
So is there only one breakout room? I think I'm unable to join the other one. So I've been trying from that.
Yeah, in 2 minutes, all will, 2 seconds, all will be here, Sunisha. You
Okay.
can, no worries, all are there, all are there. That's, yeah. Okay.
Okay. I hope you all had a good discussion in your breakout rooms.
Yes.
So can
Yes,
any of
good,
you
Aditi.
share what you have discussed?
In the group number 1, we discussed that there are short-term specialized treatment centers and long-term specialized treatment centers. But the examples of community treatment centers were less in our group.
Oh, okay. Okay. Thank you so much for that sharing. Oh, what about the other group? I think there has only been one group.
Yeah, no, we shared, but we didn't have much time.
Right.
Not everyone spoke, just a few of us. But generally, we were only able to discuss about what kind of centers we have. So in Bangalore, the ones that I know of were the long-term residential treatment center. And I mean, how they differ from each other. Like some are kind of like a jail where it's, closed and you cannot get out without permission.
Right.
And then there are some which are kind of open and the gates are not locked. But, it's sort of self-directed. So they take responsibility to follow the rules, sort of thing.
Right.
And yeah, that I didn't quite remember what Clara said. So maybe Clara can say.
Yeah, I also said that now we have centers in Mangalore, which are also run by medical colleges, and also there are different types of centers, locked systems, and also very few, like willingly people coming for treatment. Most of the centers are locked system. Yeah, that's what I said. Yeah, thank you.
Right. So thank you so much for the wonderful sharing, everybody. And I think that brings about to the end of my presentation. Thank you all for the wonderful participation and listening.
Thank you, Sunisha. Good, good.
Thank you, Sunisha. That was lovely way, very nice presentation. Lovely way to start by. So it's a very nice way to connect to participants who are new to you. Just ask them to share how their day was. And I love the activity of sharing emojis. So everybody is safe in their own zones, but yet you get connected to everyone. Lovely way. Made it very interactive, very clear diction, very clear explanation, simple slides to follow, no extra nonsense here and there. It was very, very clear. Ended, I loved the way, I thought you finished once you finished the slides, but then you had an activity, which was really nice, because it's another very nice way to end a presentation by making people think about what they have learned in that presentation. How does it apply? And once it applies, it makes sense, actually. So
Yes,
if I'm
ma'am,
able
that
to
was my
apply
goal.
what I learned, so that was wonderful. I loved it.
Thank you. Thank you so much.
Francis?
Yeah. Sunisha, you did excellent.
Thank you, sir.
What I liked the most was you always kept a smiling face.
Thank you.
When a trainer is so confused, so excited, the trainer cannot smile. If you are smiling means you are very clear about the topic. But I have an advice for you.
Yes,
That
sir.
is, please don't attempt to do break rooms unless you have time. You had
Yes.
a 2 minutes, 30 second or something.
Yes,
With
yes.
that, yeah, with that you cannot do a breakout. Of course, that was good idea. That activity was good. But you always keep and understand that if you don't have at least 7 minutes, 5 minutes for discussion and 2 minutes for conclusions. Otherwise, please don't do it. Otherwise,
sir.
all the part of the discussion, the presentation was excellent. I again tell you, I am very happy with your smiling face.
Thank you,
Energetic.
sir.
That was an energizer. Very good.
Thank you,
Very
sir.
good.
I'll keep that in mind about the breakout room for the next time.
Yeah,
Thank
very
you.
good. Very good. Very good.
Okay, Sunisha. So, being the youngest participant of this ToT, definitely you have exceeded our expectations. You have done well.
Thank you.
No doubt about that. Okay, and topic was clear, and you were very cool, and as Francis says, very confident and smiley, and then you presented what you really want to know, have to present. One or two small observation, like, I mean, I don't know whether you have taken this matter totally from the UTC book or from the, I think it's from some other,
No, sir, I tried.
UNODC, but it's fine. That's okay. Settings are always the same, like no OPD or no residential outreach, like that. So that's fine. But when you're training on behalf of the UTC sort of thing, always prioritize your presentation from the UTC handbook, like and then you can take additional references from the other things handbook. That's what even Colombo plan was telling us, like stick on to the training manual which is given to you. So that's one thing. Otherwise, good that you are adventurous. So with 2 minutes also, you could get into breakout rooms and got something out of it. So that's fine. So, but maybe those questions, like in most of the countries, they would be using all this, like OPD and residential and all. So anyway, I mean that I think they have come out with clarity also. So on the whole, I would say you have very good future as a trainer.
Thank you,
have a
sir.
long way to go. So
Yes, sir. Thank you.
yeah, did the first step. Thank you.
Thank you, sir. Thank you for the kind words.
Yeah. Who is the next person?
Can I go, Lawal?
Today we have
Ismail
Devika also
Lawal
with
is
us.
saying he can go. Thomas?
Yeah. Who is
Lawal.
doing?
Lawal.
Lawal. Yes.
All right, okay. Can you see my slide?
Oh, you concluded already. Yeah.
Okay. Can you see my slide?
Your
Yes.
volume also a little more, Lawal, if you can speak to the mic closer.
All right. So can you see my
Okay,
slide?
fine, great. Yes,
All right.
we
So
can.
Yes.
good morning, good afternoon, everybody. So I'll be making a brief presentation on assessment and treatment planning for the next few minutes. So I just want to seek your indulgence to look at what is assessment. And from definition, assessment is an in-depth gathering of data and information that are typically conducted at treatment initiation. This is just needed to be able to get a prerequisite for developing a treatment plan. And most often, assessment is an ongoing process which the counselor collaborates with clients and others. And why there is no question that is accuracy, assessment is primarily about building a relationship with the client and also with the care provider, such a way that you can be able to build a trusting relationship and be able to achieve a therapeutic alliance in doing it's being done. So assessment is basically your first interaction with the client and being able to develop a trusting relationship with them so that be able to also understand what are the treatment plan and what are the motivating factors for the client to be able to come and also receive the treatment. So basically, there are many aims why we do assessment, and these are just some of the few aims and objectives for why we do assessment. First is to determine the extent and severity of the problem, to determine the client level of maturation and readiness for treatment, also to ascertain concomitant problems such as other mental illnesses with the patient, and also You can also use it to determine the type of intervention that will be necessary to address the problem, and also assess some of the resources that are available in terms of family support, educational support, financial support, and so on. And that can also be used to engage the client in the treatment process, and also what type of intervention you need to do. I know we have attended a lot of training, but I just want to ask us, have we been able to expose to any of the tools that we use for assessment? If one or two people can just tell me some of the tools that you have used before in doing assessment of a patient. I just need one or two from the class. Any response from the class? The tools that you can use for assessment.
One is SOAP.
All right, thank you. Clap for him. Next. Which other tools can you use for an assessment of a patient? All right, so maybe not to waste our time, I will introduce us to some of the tools that you can use for assessment. And a lot of tools are actually available that we can use, but just to be able to know that in a patient, you need to look for screening, assessment, and treatment planning and documentation. So in mental illnesses, documentation is very key. And that is why we have a structure forms that you can use in doing the assessment. And these are some of the things that I've also explained, I will explain earlier on. Sorry. So these are some of the essential forms that can be used for documentation, and we'll eventually take them one after the other. However, we will not be able to exhaust the description because of the time. However, we have what we call intake form, the screening form. Can somebody also mention the other forms? The intake form, the screening form, the assessment form, and which other form? Narrative summary. Somebody mentioned SOAP earlier. And also we have the way, okay, continue
and
care.
Also, in assessment, for a deeper assessment, we can use ASI, Addiction Severity Index, which is very detailed and it is holistic. It takes into consideration a lot of various spheres.
All right. Thank you very much. Thank you very much for that. So these are just examples of the form. And I believe at the end of the class, I'll be sharing some of the form with you. But this is just to introduce you to some of the form that are being used. This is the intake form that we mentioned earlier on. The essence of the intake form is just to be able to take some of the basic information about the client in terms of their name, their date of birth, their address, their marital status, and also get some of the need or purpose of visiting the services, and also be able to provide some of the prevailing problems that the client is facing. And I'm sure somebody also mentioned on about the assist form by WHO. This is also an assessment form, and that is being used for also be able to assess in screening a patient. You want to use this assist form to be able to actually understand in which of the drugs or area is the patient having issues. You want to ask, like maybe they're having tobacco problem, alcoholic beverage problem, cannabis, cocaine, amphetamines, inhalant, sedative, hallucinogens, or opioid. However, one of the things you need to do that when you are doing intake and screening form, you need to get what we call the patient buy-in and trust. So you need to let the patient understand that all the information they are providing, there's going to be confidentiality, and also they are well protected in providing their form. And there is no coercion when you are filling the form. And this is the assessment form, addiction severity form. This is being used to also assess the level of severity of addiction. And you use this is almost, it's just a screenshot of part of the form. However, you have a bigger part of the form that will be able to almost about 7 or 10 pages, that when you fill it, you are not able to identify what are the major level of severity for the patient. If you look at my cursor, you'll be able to say, okay, if it's tobacco, based on your screening from the addiction severity index, if a patient score is 0 to 3, it may indicate that there is no intervention. But if we score 4 to 26, it means they receive brief intervention for tobacco, or if they score above 27, then they need more intervention for that area. So this, you use it to calculate and be able to identify which other area that the patient needs serious intervention when you are talking of this. Then this is our narrative and treatment form. On the left is the narrative form, and on the right is the treatment planning form. These are also used, the narrative form is what you use to describe what are the things you get from the patient, explanation of the illness, the strengths and priorities that you want to achieve, stage of changes, also your final diagnosis, and you develop your hypothesis on what you want to treat the patient on. So when you get all this summary, you use that now to develop your sample treatment plan, where you now look at what are the strengths from based on the what we have said earlier on, what are the patient's strengths, what are the weaknesses, and what are the potential goals and objectives of your intervention, which you now use to describe what are the things you need to follow on from pages to pages and from time to time in terms of managing the patient. Then you have your SOAP, which is the summary form. Who can tell me the meaning of SOAP?
Subjective, objective,
yes.
And P for progress, yes.
All right, thank you. P can also be for plan or for progress. So these are also the meaning of, so that you want to know how you are progressing with the treatment and managing of the patient. While you have, if you're able to manage the patient successfully, you have what we call the discharge summary form or continuation plan form, where you can be able to, occasionally you may need to refer the patient to another place or another place to continue the treatment. You can use it to be able to do that. Then finally, we have the consent or waiver form. Occasionally, there may be issue with maybe your employer, or there may be issue with law enforcement agency. You need to get the patient form or release of patient information to law enforcement agency, and these are the form you will use. And the patient needs to understand and also be able to get this clearly before they fill it and sign it. And these are also used eventually. So finally, I just want to ask us before we close, can you briefly list some of the tools we have discussed today for me? Can you list some of these tools? Intake form, yes. Severity index form, yes.
Screening form.
Screening form, thank you. Next.
The narrative summary actually includes like, what actually the client also said, as in the SOAP notes. You have to actually mention what the client said, which is subjective, and what I think is objective. And, yeah.
Thank you. Thank you very much. Which other form?
Progress notes.
Progress note. Thank you very much. Then final one that we mentioned today. We also talk about the what? Waiver or informed consent form. So we need to remember all this when we are managing a patient and be able to use it to also document appropriately. What I would advise that you can also have a list of this as part of your SOP so that you know what to use at every particular interval or when you are seeing a patient for proper management. So in conclusion, we say assessment is a process of defining the nature of the problem, determining a diagnosis, and developing specific treatment recommendations for addressing the problem or diagnosis. Assessment is broader in purpose and scope. So they are structured way to collect information on the nature and severity of substance use and problem a person may be experiencing. So these are also very important when you are talking about what? Addiction management. Thank you very much. And I think this is the end of my session.
Laval, I have a doubt. Is the informed consent done before the screening, or is it done before admission?
Yes, it can be done at any time. You can do it before the screening as a way of intaking the patient, but you can also do it at the end. So it depends on the nature of the client and also where you are also practicing. Because you need to first of all have your intake. It's like you go to a regular hospital, you need to get a card first to see your care provider, isn't it? And at that point, you are not collecting any informed consent. So this is just to get a basic information around the patient. But when you are going to other care planning process, then you need to take a consent form from the patient. Thank you for that question.
Okay,
Any other question?
Ismail, I have a question.
Thank you. Go ahead, ma'am.
Can I ask you? Yeah. So as you say, if the informed consent is at the end, how are you going to talk about the confidentiality and breach of confidentiality when you're doing assessment and all those documents? I just want to know that.
Okay, yes. Yes, so I said informed consent can be done after you have done your intake of the patient, not the first thing you do for a patient or for a client. So it means you do your intake. you fill your intake form. Then from where you have gotten the information, where you are now going to assist to be able to get all the other information, you now need to take a consent from the patient, because taking that consent will make the patient to know that they are going and be able to be relaxed. However, in some situations where patient is not very confident, or maybe the patient is unconscious or cannot reason properly, so you may be able to also take some of this information, while when patient comes to life and they can be able to also take an informed consent on their own, then they can feed that. But before then, you cannot release any of the information to anybody until when the patient can be able to feed the informed consent. Thank you.
All right, thank you.
But I also need more guidance from you as my trainer.
Okay. Anyone, any other questions? He has time because. No questions?
I'd like to know which country Ismail Bhai comes from.
Okay, I come from Nigeria.
Nigeria, okay.
Yes.
All right.
Thank you.
Okay, Ismail, thank you for that presentation. So just to let you know a couple of things. First is, I would tell you technically you need to improve little lighting on your setting because we could hardly see you. That's point number one. And secondly, I think the informed consent part is a little dicey as far as I think. Before you start any of the interventions with the client, you need to ask his permission. So as you said very rightly, if the client is not in the state or in a state of intoxication, not able to write, you have to wait for him to come back to normalcy. Sometimes you can do the medical detox, but then again, informed consent has to be given by his family members. There has to be some documentation as the patient was brought in an intoxicated condition, and that's why the medical treatment is being done to him, which is detox in our case, in substance use disorder treatment forms. And anything you do after that, any of those forms which you want to use, you need to first talk to him about what this treatment is about. So you can ask him his name, make him sit down, and then tell him that this is a kind of a treatment that you might be benefited from. And would you be willing? It's like, asking permission from him that, are you willing? So I think that needs to be a little firm on that. I don't know what Francis thinks about it, but that has to be done at the beginning. Secondly, I thought there was too much written material on your slides. So next time when you present slides, just have points and then you explain everything. So that's easier to look at. And don't read from the slides. You have something on your own which you can explain. So that was another thing. One more thing is, you asked about what are some of the, you asked a question in the beginning which struck me, what tool is used for assessment? You explained everything, and then somebody answered SOAP. And you said, okay, so I think SOAP is not an assessment tool. SOAP is, as somebody answered, subjective, objective. So it's a progress note which is done after every counseling session. Yes, you very rightly explained later on, Ismail, which was right, that progress note is done for checking the progress of the client on a day-to-day basis. And so these notes are done on day-to-day basis. As you see the client, a progress note is written. What is your assessment? What is your, next step about it? So that was something which is not an assessment tool. And another thing, all the documents are not assessment documents. So they are, you said they were assessment documents, but then you explained this is an intake document, which was right. Then there was a screening document, which was again right. So there are different purposes why you have different documents which have to be used in an order. So you do screening, you very rightly explained again, just to know whether the problem exists. So that cannot be called as an assessment document again. So just say these are some of the documents that need to be filled, which you said very rightly. Another thing, somehow informed, I didn't understand when to use which form. So you showed a whole lot of forms to these participants, but I didn't know when to do, honestly, I don't know when to do what is narrative summary. I didn't understand that. when should I write that narrative? When should I write a treatment plan? So what you need to do is when you are actually trying to teach these different things, go in a particular order. And then you say that once you're finished, once you do screening, then the further intervention, if the client is ready for whatever interventions, then you do a further assessment, like using ASI, as you said. And after assessment, you write a narrative summary of that assessment on which you base your treatment plan. Because unless you do that assessment and a narrative summary, you can't write a treatment plan, which is a live document. So you have to actually put it in its, in its slots. It has an order to follow, actually. So next time when you present, you can just use all these forms, but place it in an order. Yeah, thank you. Francis?
Yeah, Ismail from Nigeria. Good evening. What is the time there? Good morning or good afternoon?
Good evening. It's afternoon. This is 1:30 p.m. in Nigeria.
Okay, good afternoon.
Good afternoon.
Actually, you were very confident. But as Aditi ma'am said, that confidence level in explaining, but not in that order of putting the things together. Much of the things has been told by Aditi ma'am. But as Aditi ma'am said, the screening is done initially. But assessment is an ongoing process. You can assess again and again. And taking the informed consent, not only for treatment, even when you do a screening, you have to take the informed consent. So informed consent is taken in the initial treatment center, treatment when you begin. Especially if you are doing it to children, you have to take informed consent. You also have to take assent. That means permission from both parents and the children. So there are many things about informed consent. I think it's clear for you. And what Aditi ma'am said, it was not in order. Absolutely, it was not in order. Somehow you explained everything, but somewhere something were missing. Maybe that you did not utilize your allotted time. You see, you finished by 10 minutes. You had 5 minutes more. Had you planned it in that way, you would have definitely presented it in a better. I don't mean that it was bad. It was good. You would have, a little more excellent way you can present. So next time, please keep in mind, please go in order, explaining. And always remember that one of the important assessment in addiction field is ASI, like what rightly said by Raman. That is the one we usually use because that is elaborative and that also gives you to discuss various spheres of or aspects of addiction. So that's good. So next time, please keep in mind to utilize your maximum time, but don't exceed your time. That is the way you present yourself, because it's not that something that you are presenting. It is something like ToT. You are presenting to prove yourself as a trainer. Of course, you are a good trainer. You can definitely do. Only you need to just check on your knowledge level, where you want to present, what you want to present, put things in order. That's what I want to tell in short. Very good. Thank you.
Thank you very much for the feedback.
Yeah.
Okay. So Ismail, you were like a super fast expresser. Very well. You finished very fast, reached on time, not much before time. So many people must have been happy also. So that way it is okay. No, you are very fast. But I believe you are a professor in a university, so you are used to teaching, no, like a teacher, like. So this one also was more like that, but you were very fast. I think if it was a little more slow, maybe people could catch up, especially because the tone of your voice was also more or less similar, like not ups and downs and all, very smooth. But so those things just keep in mind. And then one more observation: your topic was about assessment and treatment planning, because about the brief intervention, screening, and all somebody else have done already. So you could have started like that. Just do a recap, like somebody else have done that. Now I will speak about assessment and treatment planning. In assessment, what all things are? What is assessment? Why we should do assessment? And then how it leads a therapist and a patient to the treatment planning and brief summary, all lot of things, like that, little systematically. If you had gone, good. But there were so many things in your thing. In 10 minutes, you presented so much. So only thing is keep in mind whatever Aditi and Francis have said. So I don't need to repeat it. We don't need to go very fast and finish it fast also. Use the time and then involve the people, involve the participants a little more. So that way things should have been a little more better, but you can definitely do well. Congratulations and thank you. Yes. Now, how many have completed? 2, no? 2 have finished.
Sir, I'll go next.
Yeah, you can go next. Yes. After Chatura, we'll take a small break.
Who is this?
Chatura Nagarjuna.
Chatura
Okay. Chadura.
So you want us to share, no, Chatura?
Yes.
Okay, Roshan. Can you see now?
Yes, sir.
Yeah. Okay, go ahead. Your time starts now.
Okay, sir. Hello all, I'm Chatura Nagarjuna. I'll be presenting on aftercare today. By the end of the session, we'll be knowing definition of aftercare, the need for aftercare, and the components of aftercare. Next slide, please. Aftercare is considered a journey to recovery or a continuum care. Can anybody just share a little bit? Do you think or do you consider this as a journey to recovery, aftercare?
Yes, it's a journey because there is no end to this journey, hopefully. That it continues till the person's last breath.
Yes. Okay. So to say the journey of recovery continues even after treatment and rehabilitation and is long and steep. Since clients may take a year or even more to complete this last part of the recovery journey, they need support and guidance during this period. Next slide, please. Can anybody please read this?
Aftercare refers to services that help recovering drug-dependent persons to adapt to everyday community life after completing earlier phases of treatment and rehabilitation.
So, aftercare provides an opportunity to address important issues and problems associated with abstinence and recovery. Aftercare provides a safe environment for continued support till it is no longer needed. Of course, some may need more time, some may by themselves, they'll be able to manage. Next slide, please. No, previous slide. Let's take previous slide. Okay. Now, before continuing, I just want to know, like it's a question, should aftercare be an integral component? Before there is a question, like before we continue, should aftercare be an integral component programmed into a treatment and rehabilitation service? Do you think it should be a part of rehabilitation service planning? What do you feel?
Yes.
If it is so, then what areas as a nutshell should we cover in the aftercare? Like, for example, training to prevent relapse and other crises, managing family and other relationships. Any other areas you can just share? What we can cover in aftercare?
And also returning to a workplace. Oh, yes. Sorry, someone else was saying.
Yes.
Returning to the
work and employment, yes.
Yeah. And also other social activities.
Yes. That is, can you say recreational activities?
Yes, exactly.
Yes, and then overcoming stigma and shame from the past.
Yes.
Developing new insights, making new friends. So all these are also maintaining some new or improving some skills for maintaining recovery. So in a nutshell, we can tell it should focus on reviewing and consolidating the gains made during treatment and aim at whole person recovery. That is some strategies for being drug-free, crime-free, and being gainfully employed. Now, when we talk about aftercare setting, aftercare services may be offered on an outpatient basis by the designated staff of the treatment unit. Alternatively, aftercare may be offered in the community by trained community volunteers or by aftercare self-help group. Next slide, please. Can anybody read this?
Continuing the care plan. Documented plan of action developed before discharge or transfer to another level of care. Structured, goal-oriented list of services developed jointly by client and counselor. Includes recovery capital and possible challenges.
Okay. So this clearly stresses that this continuing plan, that is structured goal-oriented services, are planned jointly by client and the counselor. And they include recovery capital and possible challenges. Next slide, please. So now we are talking about components of aftercare, individual counseling. Now this is one-to-one. Close care is provided for a person who needs help. Now some of the areas are here, like addressing the issue of drug craving. It can be like triggers, tracking of craving urges, anticipating situations that may lead to drug use, handling craving, counteracting euphoria and the desire to test control, identifying tools to prevent relapse, handling shame, guilt, depression, and anxiety. The second point is establishing a new social network. Now, can anybody give me an example, like how can a person establish a social network?
One of the example I would suggest to anyone in recovery is, now previously if the person, like say, was an alcoholic, his friends most probably would have included people who also drink,
yes,
and the bars and all this kind of playgrounds, So
yes,
he has to change that and start going maybe for this 12-step programs, people who are sober, take part in sober activities.
Can we say as non-drug using persons and peers?
Yes, yes. Initially, it is better that he sticks to this recovering people, and then slowly he can, like you said, develop this social contacts. If he's unmarried, he can see whom he can marry. Things like that, social things.
He can also do some fun activities, no? Going to trekking with them, yes, swimming.
Yes.
Something
Yes,
that doesn't include the usage of chemicals, like establishing healthy social activities. Thank you.
Yes.
Next one is...
And also, Chaturaji, sorry to interrupt.
Yeah, no,
one
please.
of the most important things I think is for the person to learn how to celebrate without substances.
Yes. Yes.
Yeah.
Between A and NA, yes.
Yeah.
Yeah, okay. Thank you. Next one is beginning or resuming new roles and responsibilities. This can be as an employee, worker, student, family member, a parent, a son. Can anybody give me an example as a parent, how a person can resume or develop new responsibilities at home? How can he be part of the family? As a parent, how can he help at home?
Help his children during studies.
Yes, helping in the homework, going to parents-teachers meeting. All this a person can help. Also, as a family member, he can understand family dynamics, rebuild personal relationships, understand what is enabling behavior. All this will be a contribution to the family. Next one is understanding social dysfunction. If because of the overuse of chemicals, maybe there is a lack or poor intimacy with the couple, this can be addressed slowly. Once he stops, maybe he can revive it. If there is any problem, then always he can be referred to a specialist. Developing new skills. This can be like stress management skills, anger management skills, relaxation techniques, enhancing self-efficacy for handling situations. Basically, these are coping strategies. Learning daily living skills. This can be money management, housing, legal assistance, knowing the importance of personal health, diet, exercise, hygiene, checkups, enhancing spirituality, and finding meaning in life, maintaining balance in life. The last one is continuation of medication. What do we mean by continuation of medication? Can anybody please? What is a medication he may need? Or what?
It might be a very simple thing like that vitamin tablet on a weekly basis. It might be also if there's co-occurring disorders, they have to continue them. Or if the person has physical disorder, like say diabetes, they have to make sure that they take that. And especially when it comes to mental challenges, family should be involved in the recovery process, because many people who have this, they tend to avoid or forget taking their mental health pills, medications.
Yes. Excellent. Also, aversive drugs therapy, whoever takes the DS tablets also, maybe the counselor can help the person get it. Yeah, this can be done. Next slide, please. Okay, these are the other components of aftercare. Next. Okay, family counseling. Now, family counseling includes helping family members learn new strategies to cope and relate to each other, resolve conflicts, and prevent relapse. Now, I can give an example here where we had a couple who after the discharge, they were facing some problems, so they came back. The problem was the wife was always calling the husband whenever he goes out of the home, whether for meeting his friends or work. 15 calls, 15 messages he used to get. So this was frustrating for him. And then again and again asking whether did he drink. There was a lot of trust issues. And worrying about husband was more. When we closely monitored the case, we came to know somewhere the wife had no self-care. Like she never had her own care for herself. Like previously, before his usage, excessive usage, she had friends, she had relatives, she had her hobbies, grooming, self-grooming was there, but all this was lacking. Now she was all more worried about where is husband, what he's doing. So somewhere we helped her to revive these things back. And for this worry part, we helped her with mindfulness-based stress reduction, where she started reducing to worry more, and the husband was also able to do his work. Slowly, as the days passed by, they were coming for sessions. She was also they were able to gain trust with each other. Okay, next. Occasional rehabilitation. Can anybody just share what is occasional rehabilitation? How can we do an employee assistant component in aftercare services? Like, for example, such as socializing with fellow workers, helping the person to socializing with fellow workers, coping with routine and monotony, coping with authority, not being able to speak up. All these problems can be addressed. Also help him to relearn certain occasional skills or develop some new skills. And then also at times aftercare staff can also maintain a contact with the employer just to get a feedback how he's doing, or also make a non-intrusive visits at times, of course, in confidence with the recovering person, to help him if there is any crisis in the workplace. Also conduct group discussions on job-related issues and assist in job-related decision-making. Next slide, please. Okay, other mutual self-help group. Now, mutual help programs are alternatives or enhancements to professional counseling. Participants in mutual help groups support and encourage one another to stay drug-free. Now, the best example, as Mr. Raman sir told, we can give 12 steps program. AA and NA can be stated here. Any idea what is the criteria for membership for AA and NA? How can we become a member? One thing is we were using before, that is there. But what is that makes me, I can get membership in AA or NA?
May I answer that? I'm talking too much, but anyway,
yes,
seeing as no one is up. The only requirement for membership in the 12-step program is a desire to stop drinking or using.
Yes. Excellent. Yes, correct. Yes, sir. So desire to not to use. Okay. Next slide, please. Next slide. Yeah. Okay. Next slide. Just go. Yeah. So we have next slide. Next. Again. Next, please. Again, please. Next. One more. Oh, thank you. Okay, so we have here all Al-Anon, Al-Latin, Al-ToT. We have all these are for family members, like we were talking about mutual self-help groups. So we have some of them I've given here. We have SMART and rational recovery. These focuses on motivation, urge, thoughts, feelings, behaviors, and satisfaction. Teaches increasing self-reliance rather than powerlessness. And also Celebrate Recovery is faith-based or cultural tradition. It focuses on that. Because a local church, temple, or spiritual group often hosts them, they also provide linkage for the participant into a broader support network group. And also we can, additional components can be child care for individual sessions, transportation for treatment in the mutual self-help groups. Okay. Next slide, please. Next slide. Can anybody read this?
Continuum care, sustain abstinence, develop a deeper understanding of self and others, increase responsibility, work on resolving family difficulties, consolidate, reinforce, and become comfortable with life challenges, integration into the community with a meaningful role.
So this tells what we understand here is recovery does not include staying stopped, not drinking. It also adds something where we have to have a meaningful life, qualitative life, getting integrated to the society and understanding our own self. And also the aftercare staff should have networking and coordination with many agencies. Next slide. Thank you.
Chaturaji, I just wanted to clarify one thing.
Yes.
You see, you basically are talking about continuum of care.
Yes.
And there is continuing care. Now, what I understand of continuum of care is that it touches all aspects of recovery, whereas continuing care is, you go on and on with your recovery. Am I right?
Yes.
That understanding, okay.
Yes. I also had a confusion, so I asked Aditi ma'am whether aftercare and continuum care, actually aftercare word was not there in the book, so I was just a little bit confused when I was looking. So she said it is continuum care.
Yeah, okay. Are you done, Chatura?
Yes.
So coming back to Raman, your thing, continuum of care and continuum care. That always is a confusing word. Continuum of care is the entire gamut of interventions that we do with a client. It's a continuum. The whole continuum of care, right from your, outreach to end. Whereas continuing care is kind of a aftercare. So I think you know that. Yeah, you said the same thing. Right?
Thank you, Dr.
Okay.
Aditi.
Yeah. Chatura, 2-3 things. Very nice presentation, but you were sitting in an express train. That is one thing. Your speed was
fast.
Of course, it was. You had a very pleasing slides and very clear diction and explanations, lots of examples. So those were very positive things. I think you had only 2 participants in the class. One was Raman and one was Clara. Everybody else was not there, only disappeared, I think. So what you need to do is, when you saw, and even Raman realized that he was answering too much, you should have just holded him on the side that, Raman, I know you're very curious to answer, but can you just wait for a minute and let's see somebody else. Let's hear from someone else from some other country. Okay, I mean, participants want to answer because you will have participants like Raman in the class and he was not dominating. Nobody else was coming. He was very quick. Whatever he answered was correct. But you were very happy that one person is answering. And in between, thankfully, you gave a chance to Clara. So that was something that you need to really address. Otherwise, everything was nice, but you need to really bring in all other participants who may want to share something, but they were not as quick as Raman and Clara, probably.
Ma'am,
So
I was also worried about the time, ma'am. I was just seeing the time before.
Yeah, time.
Yeah, so you should have had little lesser slides, lesser talk. Then another thing, you were asking for examples. And if 2 seconds somebody doesn't answer, you would give off the answer. Now, again, don't do that. When you ask, can somebody explain me, what do you mean by aftercare? Or what do you mean by whatever recovery? Wait. Just pause. Don't be in a hurry to answer. People take time to articulate what you have asked. They take time to think suddenly, what example can I give you? And they will come out with an answer. But only if you give them time. If you're going to rattle off all the answers again, nobody is going to be participating in your class. And that's exactly what happened. You were trying to make them interactive, but it didn't happen because of your speed. You were too much in a hurry to read off. You had something there in the mind to be delivered, and daga, you delivered everything.
Yes.
Now, That became very, very, you had a different tone of voice. Everything else was very nice. Only thing is keep that in mind. That's all.
Okay, ma'am.
Yeah, Francis.
Yeah, Chadura. Ma'am said a lot. I just want to tell you, I was listening to a news reader. Very simple, very accurate, meticulous language. Everything was good. But the thing was that you forgot about that you are a trainer. It doesn't matter. You had two students who used to answer, and Raman did his part. Clara also did her part. So only what I want to say, you have ample knowledge about the topic. That is sure. Only you need to cut down your materials, reduce the power PPT slides number, and then go discussing. As ma'am said, you elicit answers from participants. But it was very nice to listen to you, I am sure, because you're not like ma'am said, you are just delivering the message. Thank you very much. Keep up. Only just think about this in mind when next time you do. That's all. Otherwise, it was very good. Thank you.
Chachura, you did well, no problem. So things were clear. So it was a pleasant to listen to you because you had a beautiful voice. All those things are good. Like I don't know, like I was looking at you, it was looking like no, you were sitting in a mist or snow or something like no, I don't know. The background of your screen also. Maybe the next class we will speak a little bit about all those things also. So that is also important, like no, when you interact with people. So it was not bad, of course, you did, but a little more training skills if you can adapt, then you can do better because you have the stuff, you have the clarity, you have the confidence you have, and in all levels, you have all the potentials to become a good trainer. So these points, no, some very technical points were raised by Aditi and Francis. Keep that in mind. And next time you can prepare in very cool, like 15 minutes. Yes, it is there. So if you don't finish it, also nothing will happen. But till 15 minutes, if you do great, people will think that, no. So that way. So anyway, nice. Congratulations. Yes, we are almost reaching 6:30. Do we need to have a small break and come back? We don't have many more presenters anyway. What do you think, Aditi, or should we just continue?
No, we can take a break, 5 minutes break, no problem for me.
We can take break, I think, no, 5 minutes break, and then we come back, yes. And then after that, I think Ronnie said he is going to present. Is that okay?
Yeah.
And then Georges Brito is there, and I think that's it. And Devika, if you want, you can also. We didn't give you a topic. You can take any topic and do if you want. You are already a trainer, so we didn't want to burden you. Since you have come today, I'm just telling you.
Sir, actually, I'm driving and I'm listening. That's why I'm not participating.
Teach us driving then, huh? Driving school. Okay. No problem. No problem, Devika. Okay, 5 minutes break. Okay, all are back from the break. Hello. Okay, okay. Okay, then yes, Ronnie is going to present now. Okay.
Yeah, yes.
That's
Just
for the
have to
George Brito. Yeah. Okay.
1 second. Let me just set up my slide. Am I audible?
Yes, yes.
Okay, the timer can start now. Good evening and good afternoon, my dear friends. My name is Ronnie. Today I will be talking about contingency management, the role of incentives and rewards in CM in the context of SUT. So just want to acknowledge first that I will be referring contingency management as CM henceforth. So what is CM? It is based on the behavior principle that rewarding a behavior reinforces it or make it more likely to repeat. So this rewarding a behavior reinforces it. This is the central theme of CM as an approach and making it likely to be repeated. What does that mean? Which means every action you take has consequence. It has a consequence. That's why it influences the likelihood of that action repeating. Whatever the consequences may be, could be positive or could be negative. CM is the way of hacking that. This is a fundamental theory in behavior psychology. So I say that because you see the principles of CM in your daily life, in your society. For instance, imagine yourself as a student in the context of learning. Okay, so imagine yourself a student and you have a presentation or a task to attempt, and you go towards your teacher and you give your task, and the teacher liked your tasks or your presentation. And now imagine you see that koala bear over there. Imagine that as your teacher. Quality work, good work. What do you feel now? You feel like you are inclined to continue putting more effort. You feel like you're getting praised for the effort that you have done. So you feel like you're gonna do more effort. And this is the principles of CM. In SUD treatment, CM means that clients are given the chance to earn incentives or rewards for their desired behavior. Let's see what are the behavior perspectives. Let's see how a person might behave when they're using substances. So it is all determined by these 3 points over here. Here you see the positively reinforced effect of the substance itself. This is one of the reinforcement you get from using the substance, and the negative reinforcement of relieving pain of withdrawal. Talking about substances often have this immediate positive effect, such as euphoria or relaxation, so that you keep using it. And what happened here is that your brain is bombarded with a lot of dopamine. What happens next when you're bombarded with a lot of dopamine? You will experience the crash. That's what this withdrawal all about. This act of using the substances over and over again just because you need to relieve this unpleasant feeling of withdrawal. So that creates a cycle of continuous using it because you need to avoid the symptoms. So this pull of dependence comes into picture. So that is very strong. So as a therapist, before we design a CM plan, we need to take a moment and really reflect on this idea that it takes a long time for the internal reward. This reward is purely internal. That's why it takes a long time. This internal reward of abstinence to be experienced by the client attempting to make majority of behavior. So as a therapist, it is very crucial for us to know the complexity of what the client is going through, the pain that's going through because of the dependence of the substances. But fear not. It is also your responsibility to show the client that abstinence is a blissful experience. This is the kind of perspective that a therapist should give. It is his responsibility. It is also his responsibility to help the client set the goals, because the client himself may not really know what the next step is, because he is already going through a lot of problem and he needs somebody to help him through the goals. Since, okay, we spoke about abstinence, let's hear it from you. What do you think the rewards of abstinence are? I have 4 spaces here, so I'm expecting 4 answers from you guys. Hello.
The better physical health and a mental alertness.
Yeah, absolutely. That's a good one, Sheetal. Anybody else?
Also to wake up the next morning and not feel
Cognitively
guilty
better
and shame.
able to, to be more cognitive about things.
Yeah, improve. Yes, you get to have
Improve mental
better
health.
cognition. That's well too, Vela. Is Suleka or John said something?
Acceptance
Acceptance.
in the society.
Acceptance in society, yes, that's the social aspect. That is also a very important.
Family
moving,
acceptance.
Family acceptance as well. Here we have 4 examples that I have shared: healthy lifestyle, employment and self-sufficiency, educational opportunities, and maintaining positive relationship. Like many of you have already pointed out these ones. So let's see what are the how we can use motivation here. These are the reward motivation. I got 3 over here. Treatment adherence. What is treatment adherence? It means when the client makes changes required while getting treatment. That is what treatment adherence is. Abstinence is very important. In fact, I could argue that it is the most primary goal in here. So it could be behavior change and abstinence. Lifestyle changes. I'm pretty sure many people are motivated to get abstinence because of the lifestyle problems that they are facing. So, because let's be honest, people who are suffering from dependence from substances, their life is most likely a train wreck. So they might have had an inner desire to enhance their quality of their life, or maybe they need to improve their finances, or maybe pay back their loan. All this can be a reward. All this can be a motivation to seek the abstinence. Next, let's talk about how we motivate behavior change and abstinence. Let's see how can we motivate, because it's a very complicated thing. Motivation, here at the beginning, I mentioned systemically rewarding desirable behavior. Systemically, we have to work as a scientist here to design a proper plan for the client, because CM is a behavior therapy that uses motivational incentives and tangible reward to help the client. So we are required to really understand the psychology of how the motivation work. Only then we can create a proper plan. Next, reinforcers are positive, pleasurable, and rewarding. See, reinforcers can be positive as well. It can be a rewarding event or object. My previous presenter, Chatura, mentioned about Alcoholic Anonymous, and that comes to my mind when people say events and objects as rewards. Because they have something called as second birthday. They recognize the achievement, and they acknowledge clients' efforts, their milestones, and their successes. They show it through certificates or awards. So that can be an object that can be given to the client or given to the person who is on the journey. So just like the positive reinforcement, negative reinforcement also are effective. Okay, so there are a lot of techniques we can use. So, but all of these techniques are guided by these specific principles. I'm just going to read it out. Identifying behavior that is observable and measurable. okay, how do we identify behavior as observable and measurable? For example, say if you're targeting abstinence as a behavior that you want for the client, you can have an on-site drug test, can measure their drug and alcohol use. So then you can measure and then you can observe. Selecting desired behavior changes that can meet treatment goals. Rewarding small changes. Choose rewards important to client by asking them. Reward the targeted behavior immediately. Provide frequent reinforcement. Deliver all rewards as promised. Use escalating series of rewards for a greater incentive. Okay, we have challenges also in CEM, but let me tell you, challenges are there only to overcome. So make sure that your CEM is practical and available without too much cost or expenditure or expenditure of staff energy. So here what I meant by is I'll explain it through something that I'm using. This is the app I use. Okay, it's called as Forest. And this app uses the concept of gamifying and also behavior psychology. And how it works is that you set a 90 minutes focus time. It is for the focus. You set a 90 minutes focus time, and you get a digital sapling over here. So the goal here is to get a full-grown tree that is 90 minutes focus. So what happens if you check out your phone? Or what happens? Your tree withers and die. You don't want that, right? So what is this? Somebody can tell me what is this incentive? What is this? What is this reinforcement? It is negative reinforcement, right? That is why we want to avoid it, but it also works. And then once 60 minutes is done, you grow your own forest, you get a full grown tree, and you're proud of yourself that you've done the work. And as a remuneration, you get coin. This is also, we can also call it as token. It is also a reinforcers. What we can do is we can collect a lot of tokens and buy something else that is reinforcing. So this is the kind of gamifying techniques we can use when it comes to SVB as well. Another important one is community reinforcement. So just like reinforcement in the form of object or event, like I mentioned earlier, community reinforcement can also be a powerful approach, which uses social, recreational, familiar, vocational reinforcement rather than material reward, all that good stuff. And here it is based on the premises that environment resources can be effective in changing the substance and use. Here, so what I meant by here is we are focusing on creating a supportive environment within the individual's community to maintain the client's abstinence for substance use. So what the goal is that to encourage the clients to move away from the substance use lifestyle to substance-free lifestyle. So for that, client must do a lot of, they must take a lot of commitment and do a lot of, they need to get rid of a lot of their old friends. They need to be around people who are supportive of them. Okay, to end my slide, I would like to show this quote by Nelson Mandela, who had a significant role in liberating South Africa from the system of apartheid. And I also consider the dependency of substance as one of those larger feats of liberation. That's why here's the quote: "It always seems impossible until it is done," by Nelson Mandela. Is there anybody with questions?
Tony, what are the rewards that we can just give some examples of rewards?
Okay, rewards. There is one thing is you can always have a verbal reward which doesn't cost a lot. It is cost efficient. Or else we can also use systems like token economy, which is giving them token for the good behavior that they have shown. And you want that good behavior to continue. So you give low cost tokens, and then they can use that token to buy, maybe it could be an Amazon gift card or something like that. That is one of them. And I've also shown the app, the forest app. If you could find something that could gamify the experience that they're going through, that would be also great, using behavior psychology. Many of the apps, even apps like Amazon, you see a lot of these techniques being used. So you can use those things as a reward. Maybe also like Alcoholic Anonymous also use you can just call out their achievement. You can speak good about them. All that can be a reward for them.
So another question, Ronnie. See, rewards and celebration go together. So how do we teach, especially people who are new in recovery, how do we teach them how to celebrate achievements and successes, how to be joyous without substances?
Definitely, it is going to be a huge challenge in the beginning. In the beginning, a person, you're finding a method that can replace their substance use, which is very hard. They have gone through a lot of relapse. I mean, they've gone through a lot of dependence. It's a painful thing. So there, you have you have to be diligent enough to create a system where they are able to be around the society, able to be around the community, same community, where they're around the same kind of people. So eventually, I think that can reinforce them to really. Also, we could work with their family and parents and their siblings. So we can work with all of them, and eventually they can come out of it in search of abstinence.
Yeah, and how do we teach them how to celebrate without having this gratification of substances or acting out in other ways?
Maybe I need to look up on it a better answer, Raman.
No, Ronnie. What you said, I agree totally. That support groups, and family are the key to all this. Thank you very much.
Thank you, Raman, for your question. Okay, I think that's my time.
Okay. Very pleasant voice, Ronnie. You are a good speaker, very clear diction. You gave a nice answer to Raman right now, but you can always actually go back to him and say, Raman, you are a recovering person. Why don't you tell everybody how is that done? You don't have to answer everything. Remember, I had taught you in the beginning, you don't have to have answers for everything. You will not. So when a question like that is asked, and especially when you know Raman is recovered and he has all the answers, you can throw it back to the class and say, can somebody tell me what he's asking? So that is one thing. Sheetal, you want to say something?
That's interesting.
Yeah, this is basically a technique of negative inquiry,
Yes.
It's like when you post a question to the same person, you're asking them to explain more.
No, and very genuinely, I'm not saying just to teach a lesson to that person. I'm not saying in that way. It's just that we really don't have all the answers as trainers. So don't be too afraid to not having an answer. Just say that you said a very nice way that I'll look into it and let you know. So that is one way. Second is throw it back to them and say, many of you in this class I know are recovering people and you know it better than me. So why don't you share your experience? And just throw it back to them. And I'm sure Raman will have a long answer for that, which is going to help people. Right now, I'm not going to allow him to talk, but yes, in a normal class, I would have done that. I'll ask Raman to do it. So you have a very pleasant voice, very clear diction. I know theories can be very challenging to teach. They are for many. And so, because you have to keep giving explanation. But you gave very simple examples, very attractive slides. So they were not boring, because if you would have presented all the theories on it, it would have become very boring. So one explanation related to the brain, which you can say, I'm just saying this to you, is our brains are wired. We have reward mechanism in our brain, and our brains are wired to any positive stimulus. So you can give an example, which I normally give, and I'll say that here, is if you give me a chocolate cookie and I love chocolate cookie, then every time, I see you, I remember of a chocolate cookie. And that gives me pleasure, that by satiation, my stomach is satiated, or it keeps asking for that. So that's why people keep going back to the substances, is because they give instant rewards, which you mentioned in your program, in your talk. And you can bring that up again when you asked for life rewards. What were the life rewards that you get? And people said work, and somebody said you get back your mental health or something. Those 4 columns that you had. Now you say that these take a little more time to get, and that's why motivating them, that's where your motivation piece came in, which was at the right place. And that's why motivation is very necessary, because waiting for a job to get that, it takes a little time. Whereas I get my instant reward by instant gratification by taking my substance. So how do you change that? And that's where this piece of motivation, which you had put very rightly, comes here. So say that, people who are addicted to substances keep going back to it because they don't get instant gratification through these life rewards. They know I am going to be rewarded later, but it takes a little time. And hence, you need to keep motivating them. So that was one thing. You were almost there, but you could have just connected those 2 pieces together. Otherwise, everything else I liked. One more thing you missed out was Nitin had commented something on the chat. And all of you, this is for everyone, not only you, you need to be very alert online, because we're teaching online. You need to recognize that he has put it. Otherwise, that will demotivate. There's no reward for him, no? He doesn't get mentioned, so he's never going to reply again. So this is for everyone. We miss out that, so keep looking for the chat. All right. Good. Well, good job, Ronnie.
Thank you.
Yeah, Ronnie. A trainer in the making. That's good. You did very well. Simple language, easy to catch what you speak, very clear it was. And contingency management, it is not an easy topic to teach, because altogether you have only 3 or 4 slides in the whole curriculum. It is, I remember it is in the module 7 or something, or 3 or 4 slides. So you don't have much information about the contingency management, but you did it within the given time. You did it very well. What I liked the most was that before showing the answer, you asked them the questions, and they said so many answers. What are the rewards? And then you presented what you had already prepared. That's good, because the participants may have too many answers, but what you want to convey, you did convey. That's good. And to all others, what I want to say, this contingency management works on the pleasure principle. When you reward, people will be happy. So taking alcohol or drugs itself is on a pleasure principle. Instead of that, you give some other pleasure in form of a reward or a vouchers. And there was another question, what reward you give? And you answered very well. Actually, I would have not answered about Amazon and all those things. So that means you are much aware of the latest technological awards and all those systems. That's also good for a trainer, updating the knowledge. For example, for me, I am not updating on the technological issues. I would have told he would have been given a reward of a good dinner or a masala dosha or something else, I would have told. But that was right, the way you updated your knowledge when you said about Amazon and all those things. Anyhow, keep it up. You are a trainer in growing up. You still have a lot of time to be an excellent training on the way. Make your own way. Good way. Wish you all the best.
Thank you, Francis.
Okay. So congratulations, Ronnie. You did well, no doubt about that. So I would like to catch from what Francis said. You are a trainer in making. There's no doubt about that, because you have a good communication skill. You communicate to people very well. So with a different tone and examples, I liked actually, you contingency management from a layman's point of view. You started like that. It can be applied for the whole life, for anything. And then you have guided people to the CM in SUD management. That was very good. That graduation I like well. And then you were also acknowledging people who have contributed to your class by giving different things. And at the end, of course, I think you may not have caught it well, like what Raman was trying to tell also. Celebrating life itself is a contingency management, making people realize. Many people expect something from outside for our rewards from outside, but there are also, we can become aware of the rewards which is happening automatically in our life. Maybe family is becoming happy, social acceptance are happening, all those things. Celebrating life itself also is a contingency management, getting aware of that. So I think on the whole, I was just watching your presentation and following your slides. Beautiful. I think wonderful. Only one or two small areas where you can improve is engaging the participants. I think you need to work on a little more. You are trying to read the whole thing. Maybe just engage one or two people to read some of the points and all. It would keep people very alert with your class. And then that pointer which you used also, I found it little bit disturbing. That pointer, that big thing, it was running, dancing in your screen. I think that also sometimes, and already it was no small letters, it's difficult to catch. I think that we have to keep in mind also. Otherwise, on the whole, I think you are a trainer in the making, no doubt about. Thank you.
Thank you, appreciate it.
Okay, now Father Georgish Brito is getting ready.
I am. Is there any permission for access to the screen where I can share it?
You can. Do you want to send it to us? Did you send?
Or
you will be sharing. You have the permission already, Brito. It's already enabled. You can share. Yeah. Your timer is set down. What is it? Georgish Brito is going to do. You keep your stuff in the desktop and then, yes, it's happening. Yes, it's.
Can you see?
Yes.
Is it okay?
It's working. It's working, Georgish. You're ready now?
Yes, but I can. Is it visible for all of you?
We can't see the whole thing.
I think
it is zoomed.
Put it in slide mode. Zoom.
What is this? Anything to be rectified? Because I have 1 hour to present now.
Georgish,
Just double click the slides. Double click the slides.
You have to change the height and width of your slides because it's too big.
Control and scroll down.
Zoom.
You press control and scroll down, and then it will become small.
Yeah.
Now it is enhanced. Can you do that?
I'm unable to do it.
Try. No problem. Your time. We have not started.
George, first hit escape first.
No. Take off the slideshow. It is in slideshow mode now.
It is in slideshow mode.
No, this is basically the width is very long. You have to reduce it in the slide itself. Slide management.
Within the slide, no?
Yeah.
Frame.
Yeah. Shorten your slides length.
Is it?
Yeah. You go to slide management, slide setup. You close, Georges, you close it. You unshare it.
Escape from the slide mode, no, first.
Yeah.
And then you can.
Close it and then you do your slide. Check your slide. I tell you what is it. Just to hold on.
Should we help?
You just check your slide setup. Go, there you can do, otherwise.
Georges, you are muted. Just keep it on. Yeah. And if you cannot do it, you can just send to us, Georges.
Okay, I'm sending to Ronnie.
To Ronnie, no? Roshan or me?
Roshan. So I'm just sending. Just give me time.
Thomas.
I'll mail you.
Ronnie is not here.
Actually, my screen is okay.
No worry. Did you send it?
Just a minute. I am sending to Echoing Institution.
Oh, okay. To the email, huh?
Yeah, yeah.
Okay, fine. No, it's there. Okay, open.
You may have to change the width and height of the slide.
Yeah.
Go to the design and then you check. I think George made the height very high.
You received, sir?
It's not yet come, I think. Echolink ID, no?
Yeah, yes, sir.
Or it didn't come. But in WhatsApp also you can just it has come, it has come. No worry, done. Open.
So I have 1 hour to present, so I can take my time.
No, George, 15 minutes only.
Already it is on. Timer is on or off?
George, don't be very greedy.
No,
timer is not on, don't worry. Once
not
everything
on,
is done
not
only.
on. When the timer is on, you will have 15 minutes. That's all. Don't worry.
Now I know that I will be slotted thoroughly because I will have time for you all to give me all kind of corrections.
Good. That's good. So all others are not presenting, Thomas?
Yeah. I think there Manish is out, and then few people. I don't think anybody else. I think.
Oh.
Let us see.
Suman did not present, I think. Yeah.
Suman presented. Yeah. Super presented. Can you see the slide? Slide, is it visible now, Francis?
Yeah, it's fine. Great.
It's fine, no?
Yeah,
it's within the frame, no?
Yeah, within the frame.
Okay, George, then your time starts now.
Yes. So good morning, good afternoon, and good evening to each one of you. I am Father George Splito from Jaipur. Currently, I am working as a director and the finance administrator and of the program in charge for my rehab center. So it is of like 10 years old center. So I started to learn UTC for enhancing my own knowledge. So now it is not, I am a student. So I have very little knowledge on this addiction professional. So try to understand my situation. And I'm also going through a drama because yesterday I have one patient of my being into demise of one patient who died yesterday. So I have to do all kind of proceedings. So still there is certainly. So kindly understand me. I hope I will be able to justify the time is given to me and the topic. So what do you understand by case management? Some of your on the screen, those who are there, they can come. Those who would like to share also, you can say what is a case management? How do you understand case management? Because I can't ask all of you to come because I was not in the screen most of because I was engaged in different work. So am I clear with all of you? Can you hear me?
Yes, George.
Yeah. What do you understand by case management?
Case management is about facilitating the client or helping or guiding the client to do the things necessary in his life other than recovery.
Yeah, thank you so much, Vijit, for responding. Case management, like as a counselor, addiction counselor, as we are preparing ourselves for a professional in the addiction field, so we always face the case management. It is like a puzzle in front of us. We need to solve that puzzle. It is a problem. We need to solve the problem. So how you are going to solve that, what we will see in this class. and we have different methods we need to follow when we have a case in front of us. So how to manage the case, what when client comes, any patient or any patient we are coming in contact, so that's a case in front of us. So we need to know how to manage that. That will we'll see. And you see a puzzle, a problem, a patient coming with don't know where to move on. Like today we have the Google Map. So that is Google Map is to help us to take a right direction. Same way, the case manager is playing like in a Google Map, like GPS. So how you are? So next slide, please. Next slide. Okay. So can anybody read what is on the slide? Only on the definition part.
Definition: to assist people with complex needs, often for long-term care and protection.
Yeah, when we deal the case, it is like for us, we are just assisting them and helping them how to go about program or how to get into the treatment program. Maybe the client coming first time to us, or the client is referred by somebody to us, or we are meeting a client, or maybe challenges can differ from the place to place and the person to person and the sender to sender. So as an addiction professional, we will have the case. So we are just to assisting them and helping them. We are giving them a distinct clear about the program, what we are going to give. So unless the patient is not prepared or he is not giving his consent completely, we cannot introduce him to the program. Ethically it is wrong. Legally also we cannot do. So anybody have another definition about the case management as you have studied in the UTC 6? Anybody want to add any extra definition? Any correct? Any want to say it is not wrong or right? Anybody? I hope I am clear. You can please interact with the
Father George.
Yes,
what
please.
I understand of case management is that it's a supportive function.
Just we are now just introducing to the program. I have not fully completed the course. So regarding the definition, do you have any anything add on the case management? Case management can all the patient this come with, we have maybe drug addict are there and alcoholic, two case managers come to us. Okay, so now we are dealing with the addiction. So those are addicted only come to us. So we need to deal the case how to deal. This is the definition I have kept. So do you are you against the definition or you want to add something? Okay, I hope all are very clear with my presentation. So hope you are you all are with me?
Yes.
Yes, Abhijit. Thank you so much, Ajit. He is my classmate, so he is able to understand
yes.
my feelings. So there are two kind of case management we can see. One is the intra program and inter program. Intra program is the bringing the patient from his own residence to the treatment center. Okay, so Abhijit, can you read what is on the screen?
There are intra and inter. Which one I will read?
First one you read, intra.
Intra program. Once organization from residential treatment to outpatient continuum care.
Yeah. So when we have, yes, the next I will tell them, please read. So Indra program means, I hope you all might have been learned from the UTC. So Indra program means the person is on the residency place where we are coming, we are trying to convince him, bring to the treatment center to have the continuing care. Maybe the person may not be convinced, but we need to try to tell him to come to the program. Okay, next one, can you read Indra program? Please go back to the slide, same slide. Okay. Abhijit, can you read Inter program?
Inter program is through other programs in the community, like referring a client to a job training program.
Yeah, good. So there will be some, all the clients may not be able to come into the treatment center. So we need to assist them with their own daily lives. Maybe we cannot leave the job also, or they want to have some other thing along with the program. So it is up to us how we are going to help them with have the not disturb their own daily lives. Maybe they wanted to have some other program also along with the the what do you get, the rehabilitation program or the treatment. So do you have anybody disagree with the statement, whatever we discussed so far, or anything you want to add? All are with me?
Yes, yes. No, no, it's okay.
Okay, any doubts? So can you go to next slide? Okay, now why case management is needed. Now we will deal in this slide what is the case, how why it is needed a case management. First of all, can anybody can read the what is on the slide? Unless you all don't read, I will not go ahead because it is for you all I am taking class. Can anybody can read?
Yeah, why case management? One purpose is to enhance a client's engagement and motivation by making it easier for the client to access and engage in community services. CM, case management can help clients meet immediate pressing needs that can interfere with treatment engagement. CM can motivate clients to remain in treatment because they feel supported. CM is to ensure SUD treatment services are available.
Okay, thank you so much, Raman sir. So we may be experiencing this in all those who are working in the rehabilitation program or already the professors. So I am just an infant to this professional field. So I may be not maybe that much adequate with my the what I'm teaching, but you all may be knowing it. We all facing this. So case management is very much needed for all of us. First and foremost, we need to encourage or in order to make him bring him to the concrete treatment, not to give, we need the case management. It will enhance his treatment. So it also not only needed, but immediately also needed for him. Maybe he may not be knowing how to go ahead. So how we will able to explain to him about the whole program and understanding his own weakness and his own finance status. So we will able to meet that need. So here also we also need to add a SPD program also. So next slide, please. So there are, we have now recovery capital, 3 types are there. There is personal, family, social, and community. Now I think running short of time, so I myself will read it. There are 3 things we can see in the recovery capital. What we need to achieve through the case management is personal, family, social, and community. So personal, we have the financial, health, and safe and recovery, continuity, shelter, and access to the transportation, appropriate childcare, physical value, and knowledge and education. So then second one, we have family social. So we also need to look out of the patient's family background also. The family member participation, social context, who are in recovery, individuals involved in the recovery related social activities. So then we have the community. Community, we also need to look into how the patient is a local recovery model, how he is going to be carried out the treatment further. Then we also need to have what are the SUD treatment resources he is having. Maybe he should be in some kind of the AA group or some kind of health insurance he should have. And or does he is having any kind of mental or any medical anything. So these all things to met, then only our treatment will be completely we need to have the continued process. So next slide, please. Next slide. Okay, please go back. Okay, we have the 8 principles we have in order to have the effective management. There is having a single point of contact and be client determined and advocate for clients, be community based, be pragmatic or practical, be anticipatory, be flexible, be culturally sensitive. So I will just give just one point on each point. Single point means the patient need to have the one single person. So it is not that we need a different people for the one client, but one person can manage, will help him to have the long run program, and any problem he can contact back. And client determined. We need to also identify the client is whether he really determined or not. And advocate for the client means we need to identify really what is his problem, where he can look out for this is what we call a treatment. And community based means which community is coming from, or this community is supportive for him, or he's on the alcoholic background. And be pragmatic and practical is that the patient and Anybody speaking in between? Oh, the practical thing, what can be done? And anticipatory means then it can be anticipatory program or in the beforehand or after. We need to more flexible means we need not always fixed on our own plans. We also need to understand the how the client is ready to do the program. A cultural sensitive, what kind of culture is coming from. So we need to understand that so that our case management will be more effective. We need to follow all these principles. It is all in the SUD UTC book manual. Is the next slide. So we have the 5 functions of the case management: is assessment, planning, linkage, monitoring, and advocacy. So these 5 points we are well accessed with. Assessment means we need to fully get his details. What are details, whether his medical condition, whether he was in before also he was in the rehab center, or now he's going to be in the where rehab. Who is going to meet him? Then planning means we need to plan out how can the treatment can be done, how many the duration time and all those. The linkage means how we can make him to proper people.
George, you have 2 minutes more. Yeah, go ahead.
Yes,
Go ahead. 2 minutes.
yes. So monitoring means who is going to monitor his whole program. His program need to be monitored. Somebody need to be there along with him. And one person alone cannot manage the one patient. We need to have a support. Co-passenger need to be there. So sometimes some patients, we read in our classes, they already said that when you cannot manage the patient, you need to give to somebody else. Always need to get support. Advocacy means we need to understand what are the legal proceeding we have or what we can advise him on any problem takes place. Next slide. Next slide, please. So now this is a case manager, client, family member, and treatment center. So when you deal the case management fully, you need to come. This is a word. Case management. You are there along with your co-workers or who all are with you. Then client means the patient who comes to you. The family member is the patient is brought. Who is bringing the patient to you? Then treatment center where you are referring the patient to the treatment. So this next slide. So any doubts? And thank you so much. Any doubts? Anything to be clarified? Yes. I think now I will be thoroughly slaughtered. So I am ready for it.
Francis, you want to go first?
Okay, ma'am. Okay.
I made you. I'm going to make you a goat. Yeah.
Yeah. You can conclude then.
Yeah.
Father Georges.
Yes.
You tried to present it very well, but there was nothing wrong in your trying to engage the participant. That was good. Although you didn't engage them all in a very fashionable way. But what I would like to tell you, you did not explain the concept of case management. Or I understood it in a different way. It was not clear for me. Actually, case management means is an integrated approach to deliver health, mental health, other services. That's why we say it's a single point of contact. I don't know whether you have heard about like coordinated services and fragmented services. So that concept was not clear.
That's I had said that case management like a puzzle. We need to solve the puzzle. Because there's 15 minutes, we can't explain all through. No?
Yeah, that's I agree with you. But if you had
if you give
told
me,
that
40 minutes, then I would have performed much more better than this.
I agree with you. We didn't give you time, but we gave the same time to everybody. It was true, na? Everybody, we allotted the same time. Not that somebody got more time and you got a very little time. No. What I am telling you is that the concept of case management, the idea was not clear. Maybe my understanding, like if you check in anywhere, when you check in the Google also, you'll understand that it is a coordinated effort to deliver health, mental health, and other services in a coordinated way. So it's a single point of contact, all those things you said. Had you just told about that in the beginning and made it very clear, it would have been far, far better. Another thing I noticed is that you took 1 minute for introduction. introducing yourself. Out of 15 minutes, 1 minute for introduction is not good. You have to reduce the introduction and then you have to go faster to discuss the concepts. So probably you would have told what is case management, maybe a definition. The definition or the example or you try to connect it to puzzle is not the right clarification or rectifications. That's all I want to say, but you can definitely be a trainer. I don't know whether Aditi ma'am will agree to me or not. That's why I said it first, because she has the right to say what is also add on to that.
So I agree with you, Francis, 100%. Georges, I want to tell you again, like Francis said very clearly, because it's for your own learning, you need to get an insight about what is case management for yourself. So whatever you spoke here is not case management. The idea that you gave about including the principles, including the different kinds of whatever you talked about, functions, they were not case management. Case management, actually, the client has various needs and your organization cannot, not a single organization can fulfill all the needs of the client. So when we do assessment, we realize that maybe this client requires has dental issues. This client has some other mental issues, or this client has some kind of diabetes or a physician, or this client requires to be trained into some vocation. Now, what we do is these services probably are not under one roof where we give treatment. So these services are fragmented or scattered in the community. And case manager's role is to connect this client, which is a single point of contact. Let's say if I'm a case manager, then I connect this client to various services. And that is case management. It is not managing a case of an addict or something like that that you explained. So that is case management. And that's why all your explanations about the functions or principle, I would say, were not correct, honestly. Since Francis also said that, and I would say that because it's not fair to say that that was right. Otherwise, your voice was clear, diction was clear, you were trying to give examples, but your basic subject matter itself was not correct. So you need a little more insight or knowledge about case management. All right?
Yes, ma'am. Yes, ma'am.
So you need to go back and check that. Yeah, Thomas.
Okay, Father Georges Brito. Actually, I was expecting a sermon from you, but you have done much better than a sermon. So at least you interacted with people, took some of their suggestions, and all those things were well appreciated. I was, and you were very confidently presenting what you wanted to present, though it is right or wrong. I mean, there were some issues, definitely. I also felt, because Abhijit, when you asked Abhijit was also trying to give a very vague answer, actually, you know. So you could have made it that time. It is simple thing. It is a coordination of services, no, based on the needs of the client through the single point of contact. That is what we in India we may not be practicing that, but in many foreign countries they have that. No, a person who understands the patient in its totality and then make sure that he gets all the needed services. With the mental health issue, a mental health person is available. Things like that. No, a legal issue, legal thing. So, so that concept, if it was made very clear initially, then all the other things which you mentioned would have become little more meaningful, like, no, for the people. So, otherwise, I think as a presenter, you were pleasant, no, like that was something I was watching you. You were interactive, trying to be interactive and talking to the people. It's not one-sided, definitely. So those were good points. So which are actually very much needed to become a trainer. Only you need to refresh about the concept, what you are speaking like. No, that has to be very clear. The topic, no, like. So I think case management was there enough things in the UTC. If you had really referred to
manuals only.
Yeah, it is there actually, no. So and then there was one question we were asking among the 15 entry point questions. One was about case management. What is it? Just coordination of services. That was the right answer. So that speaks a lot, like, no, because a person comes with too many issues. So you cannot ignore all the issues and take up only addiction issue, no? So that will become incomplete treatment. Otherwise, I think I would say that you are a good, you are able to communicate well. Only the topics you make sure that you refer more and get it. That's it. Otherwise, fine. Congratulations, Georges.
Thanks so much for your first review.
Now, anybody else is there today? If not, we can spend this time now, Aditi, a little more time. Even participants, you yourselves can also start speaking about, no? There were a lot of feedbacks given to you by different people. So you may have recognized some of the issues. You may have made resolutions that next time I would definitely do better. So if anybody wants to give some little bit of sharing about your personal experience of presenting your stuff and getting feedback, and maybe preparing yourself for a better performance next time. Some little bit we can hear from the participants, no, madam, and then then we can go into further Q&A or clarifications and all. Some sharings from your side. How was the exercise on? Yeah, yes, Francis.
Everyone can tell how did they feel about the feedback.
Yeah.
When we three of us gave the feedback, what did they felt? Did they felt motivated? Actually, we want everybody to be motivated. That's what we are trying to do. If they didn't feel, they can tell that was not correct, so that we can, we can tell what actually we meant. We wanted to tell the truth, not either to put them high or put them down. We just wanted to tell the truth. That's all.
So you can give feedback to the feedbackers also. No problem.
Yeah, right.
If you don't like it, you'd say it has no problem. No. Yeah. And then we will come back to some more discussions. Yeah. Anybody from your side? Abhijit,
yes, sir. Yes.
Yeah, after Abhijit. After you.
Okay, Raman. What my experience was, I have done mistake in creating my slides. That I have understood from the feedbacks, and when I was presenting that, I was feeling that too, that I have made too many things for a 15 minutes presentation. So that was a very good feedback, and for that only I was low on my confidence too, because the thing was playing in my mind that would I able to finish it in time, and I was watching towards the clock repeatedly. So that was that was basically was hurting my confidence also, and my flow also. So what Aditi ma'am and Francis sir and Thomas sir, you all have told me, that was very fruitful, and I will.
Hey,
Hey, Raman.
I'll definitely keep these things in mind if I have a chance again. So thank you all for your feedbacks and motivations also. That motivated me to. I can do better next time.
Thank you, Abhijit. Good. Thank you so much.
Yes, Dr. Thomas. I just want to tell you, I saw one guy running down the stairs which are wet, and my writing reflex immediately made me to shout at him and say, "Be careful, don't run."
In between, Abhijit also was shouting, no, sometime back, but we muted. Anyway, that's okay. You must be there. Yes, Raman, yes, go ahead.
Today, I had a very, very valuable learning today. I'm very grateful to Dr. Aditi when she said that, when she said something, it formed a concept for me that it is all right to not know all the answers. Only then I will be humble enough to learn. Because if I think I know it all, then I had it. I should not be counselor. I should not be doing this, And the thing is, like, also in the person-centered counseling, what I learned, it is better to also ask the person who's asking the question, what do you think is the right answer? And the third thing I have learned today is also the value of therapeutic silence, which sometimes I don't practice in these classes, but with my counselees, I certainly do. So sometimes, even if there's no answer from the counselee, it is all right to be silent, because that rapport to be established when we are screening them, it has to be strong. That is the basis, I think. And for that, I cannot be in a hurry. I cannot do this express one day Bharat kind of things. Because, this has been my very good learning today. Thank you very much.
John has raised his hand. So John, go ahead.
Yes,
John, you can speak. Yeah.
I found the feedback very valuable. The two things that the tone of voice to keep it varied, and then the training as opposed to teaching. I was a teacher for many years, so I have the habit of falling into that habit of disseminating information as opposed to disseminating skills. So that is very valuable to help my mother. So thank you for that.
Thank you, John. Yes. Who else wants to speak? What you have learned? Anything new? I think we would say that most of you did very well. No, not most of you, all of you did well. So there is nothing to feel bad and all. Everyone did well. But some small changes here and there, or that's what they were suggesting. Okay, Sheetal, you can go ahead.
Thank you for giving a sharing opportunity. So I picked up a lot of clues before my presentation that the background has to be like this, the distance of camera. So ma'am will talk about many things in everybody's feedback, and I'm noting it down. And that's why I thought of using polls and all. The only thing I was thinking about is like, luckily my topic was really simple and most of the things were in the manual. But if, and I have attended earlier sessions, so I have booked for separate chapter and so on. So it becomes easy for me to prepare it well. But if at all we need some more reference material, where should we reach for it? That was one of the questions. It was coming to my mind while I was preparing.
Okay. As
like
trainers,
apart from the UTC trainers manual, I mean, where should we?
So you can look into for these manuals of Samsha. Those are wonderful manuals. Plus you have a lot of publications by UNODC.
Yeah.
So most of the Samsha manuals you can download. In fact, Sheetal, they are free. Yes. SAM, SHA. So, and they have a series.
I have few
so you can
booklets
get those materials, exercises from there, or UNODC has a lot of published material, which is probably available online. I am not very sure, but should be free of cost again, because that has been made for that. So those are the two sources which I know. And then NIDA, if you're looking for any websites, then look for proper websites like NIDA, National Institute of Drug Abuse, NIDA. Right. And they give you the latest things about, if anything you need to know.
Yeah. Right.
Okay.
Plus, I think ISUP, I should not forget ISUP.
Yeah.
Yes. ISUP publications, they keep coming out.
They're wonderful.
Yeah. They keep having webinars, they keep having some kind of thing, so you can look up for that. Anything else Francis and Thomas can add?
Yeah, what I would suggest all of you, apart from what ma'am said, is always attend the webinars conducted by ISUP, NADAC. NADAC is one of the very strong, oldest organization which will give you a lot of ideas. And also you see, they have written some treatment protocols like TIP 21, etc. You just type TIP 21, TIP 21. You will get the counseling
that is
competency.
By Samsha. TIP 21.
Yeah.
They have different numbers, as you say.
Numbers.
TIP,
yeah. So, and I mean, just by mistakenly, I just typed once TIP, and then I got that. That's how I learned it.
Yeah.
We are still learning. Although I have been here for the last 30 years, 15 years as a trainer and 30 years as a counselor, prevention worker, we make mistake. But every time we make mistake, if somebody corrects us, accept it gracefully. Don't take it negatively, accept it gracefully, and then improve. So yeah, I tell you, since Sheetal asked me, recently I was thinking about writing an ICAP exam. I already have 3, but I thought of doing 4. And then I bought an online ebook. Almost 4,500 I paid. After that, I typed addiction counselor practice questions. My God, number of questions came. And then I thought, why I bought that book? Because a lot of things are in the website.
Google.
Google. I can just practice it in the site itself. And most of them are copy and paste things. And now I am wondering whether I will get time to do those things, because I see a lot of them. Because I just typed addiction counselor examination practice questions. That's all I typed. But a lot of things came out. So what I said is, use your own sense and just type it in the Google. Like I used to tell the children, ask Uncle Google. He will give you everything.
Andy Google, man.
Andy Google. Okay. For Thomas, it is Andy. For me, it is Uncle. Okay. That's good. That's okay. Thank you. Thank you. Very good.
Thank you so much, sir. That's really helpful. Thank you, ma'am.
Okay, just one more point I just want to add is, like when you are going to teach UTC, UTC session, curriculum 1 and 2, keep UTC manual as the Bible, okay, as the basic book, definitely. Because you will be given also the slides, the prepared, slides will be given. So that will be the main. And then when you are explaining and things like that, you can take information from any other sites and all. But basically, you follow what you are supposed to, because that is one thing which you have to always keep in mind. Because now we are not giving you the slides. So you have the freedom to prepare your own slide. But when you train, you would be given the slides. So try to play with that only, So that's one point I just want to know.
Yeah, that's right. Very good, sir.
Yeah.
Stick on to the curriculum.
Yes, curriculum, Okay, others can speak also, because this is just sort of a. Sunisha, what did you learn?
So I think seeing all the presentations so far, I've learned a lot, and I've seen how different people present differently. And that was like, I was absorbing it like a sponge, and all this feedback and all the kind of presentations that were going on. So it was a great learning experience for me. And the feedback when it comes to my presentation also, I've understood how, I had a little trouble with the breakout rooms also, because I couldn't jump to the other room. But I'm hoping that, I will keep learning as I keep presenting and going about with the presentation. So it was very constructive for me. So I thoroughly enjoyed this learning. So I thank EcoLink, I thank Thomas sir, Aditi ma'am, and Francis sir for giving me the opportunity to let me learn. So thank you.
Sunisha, I thought I am the youngest in the group, but I hear that you are the youngest. Very good. Keep it up.
Yeah, Sudhisha, just to add on to what you said, actually the key to learn giving good presentation is keep giving presentations.
Yeah.
Keep training. Whenever you get an opportunity, whether it's paid or unpaid, just keep doing it. And that's how you learn how to do it.
Yes.
You will realize your own self now that, I can do this. Next time I'll do it this way. So just keep doing whenever you get an opportunity.
Yes, ma'am. That was the greatest learning for me. Thank you.
Okay, good. So somebody else? Father Georges, you can speak also. Anybody? Father Georges. Yeah.
I thank all of you, for Aditi ma'am and Francis sir and Dr. Thomas Carrier, for giving me opportunity to be part of this program. And I just didn't participate to be a trainer, but to learner. And I hope I learned it. I need to be thorough with my subject. And thank you for your corrections. And it is good to after all the presentation, it is good to have interaction with the presenter who presented, because he also might be having some kind of difficulties. So last 1 week, what I realized that time was very less, 15 minutes. Then after we go to other person, we don't even listen to the presenters, what is his point of view he wants to speak. So if you give 5 minutes after all the reviews, so he can also give his own reviews also.
Yeah.
Now we all are coming from a different background. Maybe all of you not belongs to this same additional professional background. I am just an infant in this field, learning you use UTC and SUD and all. It is new for me. Coming to this is only for learning process. But when you come to the rehabilitation program, we are already having the different challenges facing. So how to face that challenge is mainly matter now. So through learning this, you will enhance how to face these problems. So it is thank you so much. I always future I look forward to be part of further any programs or any learning section is there. Also, I especially give credit to Didi ma'am and Francis sir and Thomas sir for your generously participating with us and encouraging us with your positive reviews. And of course, thanks for your loving corrections.
Thank you, Georgish. Thank you so much. Yeah. Okay. Anybody else?
To Francis, sir, I wanted to add one more. Sir, you can go through the Quizlet.com. So Grant Sanders have given us, that is to prepare for the exams.
Oh, okay.
ICAP exam.
Yeah, thank you. Please type it on.
Sure, sir. I'll do that.
Aha, very good. Very good. Thank you.
Okay, sir. Bye.
Okay. So, Clara, you have anything to say?
Yes. Good evening to all. It was a great learning experience for me. First time I did online presentation and I was a little bit nervous and scared, but I felt really motivated to do it again. And I felt like I need less energy to do online than going to a place and spend more energy. So it's a good way to connect to many people also. And for me, it was 15 minutes were a good time because I have less concentration, like long time. So, and different people. So it was a good learning experience. I learned from many people, so many things. And, I think I made lots of points from every session. I took so many points and it was very enriching. Yeah, that's all and I thank you, Aditi ma'am, Thomas sir, and Francis sir. Thank you so much.
Thank you, Clara. Good.
I also wanted to thank Dr. Thomas and Aditi ma'am and Dr. Francis for taking so much trouble. It was really a good program and it was a great refresher also, especially for me because I've been kind of out of touch. So it was a great refresher to remember all the things started coming back to me. And I really, really appreciate all the efforts from everyone was good. So thank you so much.
Oh, thank you, Luella. Good. Luella had also suggested everyone to share your presentations, so that each one can learn from each other. So you're free to do that also.
Some have shared, yeah. Some have shared.
Some are shared, and some more people can share if you are good-hearted. Let others get it from that. Okay. Anybody? This is not a thanking session. We are not closing our program. Okay, we have one more day. Keep in mind that's very important day on whatever we have worked out with a purpose. What is it like? We have to discuss that on the next session, which is on 10th. I hope everyone will be there because 8th you have some session. Some of you are in VICE, so that's why we thought of putting it on 10th. Okay. So somebody else can speak, and finally Aditi will give you a final observations and a sort of a summary.
There is a message. There is a message from Ismail.
Ismail, yes, Ismail.
Message.
He's put it in the chat. I have a noisy background. I really appreciated the support and all the feedback. Very wonderful. Thank you. Please, I need the link to Nigeria community.
Okay. Thank you. Lawal, yes.
Yeah.
How is Dunish? Who is that? Tushima. You joined together, I think, no? It's good. Because
then there is a message from Nitin also.
What happened to Nitin? Cannot talk up.
Yes, I felt motivated and feel confident now.
No, I would like to add on to that. Yeah. So this was a really nice training session. So something very different, learning from different trainers. We do attend a lot of training sessions, who are really good qualified, when we go for it. But we never get to learn from the who are in the same pace, so we could compare ourselves with the other trainers across the country, across the globe. So this was really nice thing. So I got to learn from each other a lot. Yeah, thanks for that.
Thank you, Nitin. You have a
And I feel
beautiful
more
voice.
confident now, like
Yeah.
seeing myself along with the others.
Very good, Nitin.
Very good. Generally, I have noticed actually, people were not that nervous. Everybody was confident. You had that freedom and confidence and all. So that was something good. Sometimes in some platforms, people get so scared and all like that. Even if you fail in your technical, some of the things also you were okay to get help and get it done like, no? So that's a good point, yes. Okay, someone else? Anybody else? Sulekha madam, you did a good presentation also. You're there. Suman,
Yes,
are you
sir.
there?
I was just writing in the chat, messaging in the chat. But
You can speak up.
what I wanted to say, good evening to everyone. Aditi ma'am, Thomas sir and Francis sir. I'll never forget, when I get into Vande Bharat now, I'll never forget the speed. The speed.
You are a super fast lady also.
But it's a super fast train. But that's a in thing now in Kerala. Everyone wants to go by Vande Bharat. Okay. And it was a real learning experience. And as Loyola was saying, it's a real like a refresher course. Because for me also, I'm not very much into it at all. I don't see many patients. It's not that I've not been to a de-addiction center as yet. I would like to go to the self-help groups also, like the saying, I would like to go to all those places. And as far as I'm concerned, age is not in my favor, but I wouldn't say that. Age is just a number. Age is just a number. So I know that. So I'm still eager to learn. And my life has been a struggle. I had written in the group also how my life has been a struggle to study something. Just from being just a 12th standard pass girl. That's the time when I got married. So after that, it has been a real struggle to get one degree after another, and real motivation from my dear husband, I would say that. And also, my kids also, when they were small, they were so very supportive. So that's how I reached to this level. And I thank God for it, that I could do all these. But even now, my zeal to learn is not yet over. Even when I attended all the sessions, I was earnestly, but still I'm little hesitant, maybe because I don't know I don't know thoroughly the subject. I must learn again. So I was thinking, curriculum 1 and 2, I should definitely go through it in detail. But I didn't have the time before presenting. So that also was a little handicap for me. But all said and done, good advice from all of you. And I know I should have, and even making slides and all technology is totally, I think I belong to a generation where technology was not there, and slowly I'm getting into that. So those are all my limitations, but very nice presentation from all the friends who have presented so very well. I appreciate them. And very good. It was really nice learning. Thank you so much. Thank you.
Thank you, Sulekha. It was wonderful. All the presentations were good. And one point which you said, it is a refresher program for everyone. Just to catch up with curriculum 1 and 2, what is there, all these terminologies, all this, it was nicely brought out by the participants beautifully. Congratulations for that. Okay. Anyone else wants to say anything, or we will hand over to Aditi ma'am for a sort of a summarizing everything. Anybody else? Leslie, you are there or not there?
I'm here.
You are a powerful presenter. Why don't you say your experience?
I'm also very grateful. I'm also very grateful for the experience. I've been even telling my colleagues about, we had a visit of the mental health board. I was telling them that I can't wait to get done with this so that I can basically start training them so that they can be equipped with what I know. And they were very interested in that, such that, drug use is a problem in our country, yet we don't have good facilities or rehabilitation facilities at all. So they were very interested in what I have done so far in bringing in the substance use programs. So I'm very elated that I have gone through this experience. The presentation, they built me, refreshed me. I have debriefed. So I'm looking forward to the 10th and thereafter in rolling out the program. So I can't thank the facilitators enough for having granted me this opportunity. I think Motswana here alone, if there is any, so you can see of how privileged that is. Thank you very much, Doc.
Thank you, Leshamo. Sabati, yes. Okay,
Let's
Aditi ma'am,
wind up,
yes, take over. Yeah.
I'll say something and then Francis can follow me actually, or either way around. So there are a couple of things I would just like to summarize on these presentations. All of you did very well. We gave you very point blank remarks or whatever, feedback, because unless you get that, you won't learn. And Francis and me have gone through the same thing. We've got a lot of remarks from a lot of international people, and then that's how we kept improving ourselves. So that's the first one. It's all a small family. We belong to the same family. So don't feel bad about it's not a competition, as Thomas kept saying right from day one. We are all there to go ahead, move ahead, because we wanted you all to take over a lot of trainings. And that's why this whole exercise happened by the EcoLink. Having said that, just to summarize or give a synopsis, there are 2-3 things I would like to tell everybody. Thoroughly prepare knowledge-wise. That is the main thing and crux. So if you're confident about what you're going to speak and you know scientifically that's the correct thing, you have nothing to worry about. So be prepared about that. Make your PowerPoints exciting. Of course, unless UTC gives you the PowerPoint, you have to present those only. But if you are supposed to make a presentation somewhere else, make them interesting with less writing. So what you can do is, if there's too much writing, just put the bullet points. And then maybe you can have a little sheet of paper in your hand to, read up whatever explanations you want to give. Don't read the slides, because that even the participants can do that. So you don't do that for them. It becomes very boring. Have less slides. So see that even how much time is given to you, and depending on that, prepare slides, actually. So go at a very slow pace. So don't be in a rush, because it's initially, a lot of people went first time. I used to do that also. And I used to be told by many people, just go slow, just go slow. You're talking correct, but you're talking too much and in a very fast pace. So you learn to go at a very slow pace. Wait for people to, and let people participate. If you allow people to participate, they will. So you have to just be open about that. Wait for people to answer. If you ask a question, give them time to answer the question. And keep on saying that, did you understand my question? Should I, or change your question in a different manner so that people understand it? And last point I would say is, keep doing the trainings. Whatever training comes at your hand, whether it's a school training, whether it's a EcoLink training, whether it's in your college, whether it's in a community, whenever you get a chance, make a PowerPoint and give the training. Only thing is, as professionals, we need to present very scientific, evidence-based material. You can't present materials which are not scientific and evidence-based. So that responsibility we have as professionals. So that's all I can say, and maybe Francis can add on.
Actually, ma'am said everything, but I would say I learned a lot from you all. Because the way some of you presented excelled in a very different way. I only need to tell you that as a trainer, I like to be a humorous person. I like to use a lot of humor in my sessions. I don't know whether you all liked it or not, but as a trainer, I would always say, add humor into your curry, your dishes, because humor can definitely relieve you from the stress, and that will be an added spices in the curry that you make. That's all I want to say. The other things Aditi ma'am said already. Thank you for keep learning. Thank you. Let's grow together.
Okay, let me also say one or two small points. Of course, one is when we do not know about something, we should not speak. That is cardinal, sort of a sin if we do that. So when we are giving training, as Atiti was saying about the evidence-based things and all, if you are not clear about something, always you make sure that you ask somebody who knows about it and get the clarity about, then only teach. We don't expect that everyone will know everything about everything. So that's where that you have your trainers. So they will be available. So ask them and get that, and then only you teach. Don't teach anything which comes to your mind. That is one. Secondly, preparations for it. Technically, we know that all of us are not very good at. This is technology has just come. But one thing we can do is you can prepare yourself. Half an hour before or one day before, you can call Roshan or somebody here and then do a small sharing. Share the screen, learn by yourself instead of just handing over to somebody, because when you do as a trainer later, you may not have someone to help you. So that was also a things to learn, so that it was possible for you. If you really had a mind to get that, also be ready. So preparation for the session, I think some of you took it very lightly about that, just after coming here trying to do and all. So that gives a wrong impression, that you are not prepared, so that is something which we have to keep in mind also. Otherwise, on the whole, when we look at your presentations, I say that you can be good trainers in UTC. Only the content, you have to be very, very clear. You have to study more, do research and do well. And then only you teach. If you don't know, you don't teach that part of it. Tell them that we'll come back to you, or or something like that. So otherwise, from our side, from Equaling Institute, I don't think we can skip any of you. All of you are good. So we only have to improve certain things that we will discuss on the next day, next class. So how we prepare ourselves for our program, and how are we going to actually use ourselves, to grow as trainers, practical, trainers. That is something which we'll do next class. Okay. So that's it from our side. So thank you all. Dr. Mohammed Nasri, congratulations and thank you. You are there.
Bye,
So
everyone.
there. Yeah. So bye. Shall we?
Bye.
Was it for today?
Yes.
Yes. Bye, ma'am.
Thank you.
Bye 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 bye.
Bye, all.
Thank you. Thank you,
Bye,
Francis.
ma'am. Bye, sir.
Bye-bye.
Yeah. Thank
Good
you,
night,
John.
sir.
Thank you, Ismail.
Thank you. Thank you.
Lakshma,
Bye, all.
Abhijit,
Bye, everybody.
Denzel.
Good night, sir.
Yes,
Yeah,
doctor.
yeah. Devika, for your presence. Thank you so much. Yeah. Bye bye. See
Sir,
you.
Bye-bye.
10th is confirmed, na?
10th is, yeah, that is because 8th is not possible. Other places, and 10th is okay now. We just finished
Yes,
it, closing. 10th
Yes,
we will
yes, sir.
do, and then 10th is mostly action planning, how we really are going to beat trainers, in the field. So that we will get more clarity into that. Okay.
Okay, sir.